Uh, at this, we are going to turn over to Dr. Drost to begin the didactic portion of the
event. All right. Thank you everyone for being here. We're going to talk about frailty today, and keeping this kind of real practical, real, what you see, what it means, versus getting into the nitty gritty kind of biochemical pathways of frailty. Because if you Google it, if you look in a lot of the literature and growing medical literature around this, it can get pretty intense pretty quickly. Happy to do that at a later time if anybody is interested in biochemical pathways, but we're going to stick to how we apply this clinically. And so when we talk about frailty, when we talk about frail, particularly older adults, I think we all, we have that sense, right? That while maybe it's hard to define, you'll know it when you see it. And certainly, this lady here looks pretty frail. Right? I mean, she just looks frail, but how would you describe that? Anybody want to unmute and describe what you see when you look at her frailty? Throw it in the chat box. Find my chat again.
I see thin skin.
Mm-hmm. Maybe a little discoloration on the hand even from
maybe poor nutrition.
Looks like she has something to help her with walking in front of her in that picture.
Yep. Kind of maybe a little shadows under the eyes, kind of pointing to maybe some of that malnutrition piece again. A little thinning of the hair, maybe, kind of pulling out some of those things, but certainly recognize that she seems frail. And then how about this lady? Like, would you say that she is frail? Does she look frail?
Definitely harder to see when you don't have her hands there, and her facial expressions make her look healthier.
Exactly. And honestly, like this is the same woman, photos taken to highlight these things. But you could see maybe even how, when she's having a bad day, a rough morning to get up and get started, how maybe you do see some of those frail characteristics kind of popping out. But she gets herself together, puts on some makeup, a nice bright shirt, and maybe we lose that picture of her being frail, even though she still is. And so that's why, that concept of I'll know it when I see it of yeah, you might, but that's also, so it's I'm going to get mixed up. That's a pretty positive predictive value, right? You know it when you see it, but we lose a lot of that negative predictive value without defining it. And to touch just a little bit on the difference between frailty and failure to thrive. Frailty is really the more of the preferred language to use. The failure to thrive definition or description really came out of pediatric literature. And as much as we try not to, infantilize our older adults, focusing more on that frailty piece and that definition. However, the other trick in this is there is a diagnosis code for failure to thrive in adults. If you Google or you search, in the ICD-10 codes for frailty, there's not a specific definition or diagnosis for that, even though there are diagnoses, and we'll talk about it for the other or the diagnostic features of frailty. And so what is frailty then? I've said the word a million times, but it is one of the core geriatric concepts, and that we recognize that frail older adults are common. And the risk really of that is associated is that it's a heightened and disproportionate vulnerability resulting from multi-system failures throughout the body. And some of this is related to changes that occur normally as you age, but is not one of the things that you should say, right? It's not expected. And certainly people develop frailty at different points and different ages in life. We see that decreased physiologic reserve throughout body systems as people get older. And so that also then, when we add this frailty on top of it, really prevents a person from responding as briskly to stressors. And that may be physical stressors or an illness. That could also be psychological stressors. So loss of a family member, death of a spouse. It could be psychosocial types of losses. So, that no longer being able to stay in your home and now you have to move somewhere because you need more help. Like that's a big stress that can impact this, and people don't have the ability to cope and respond to it as well. Some of the key features is that weakness, slowness of gait, weight loss, fatigue, that just like overall exhaustion. So you'll hear that from people just like, I'm just tired. Well, what are you doing? I'm just tired. I don't have the energy to do it. It is distinct from morbidity or illness, and is also distinct from disability, even though, again, all of these things do interrelate and can kind of create a vicious cycle for people. And the biggest reason for identifying this is it has been linked to all sorts of negative outcomes, including falls and hospitalizations, and even death. So this graph is kind of picturing, that response to stress. And it is a trajectory or, points along a scale for a person. So, a non-frail person may come into a situation, a fall with a hip fracture, right? Like, so something significant happened. They had a fall, they injured themselves. They may come in, they may have their hip surgery, and very quickly, right, bounce back up and get pretty close, if not back to their former baseline. When we start looking at those who are progressively more frail, so maybe they're pre-frail, frail, or then we get to the very frail, that ability for them to recover not only takes longer, as you can see by that curve, how long that curve takes to reach this new level state, but it also doesn't get back to where the person was before, as far as that level of functional independence particularly. And this is the part that then can lead to disability. And then when we look at the very frail, they may have this insult or this stressor and really just never recover. It's that stepwise down and a continued downward trajectory for folks. And the goal of identifying this and kind of keeping that high level of suspicion is to identify people when they're earlier in this frailty trajectory, when there are interventions. This isn't an inevitable downward slope. When caught early, and there are things that have been shown to prevent the progression of frailty, people continue to live active, independent lives for longer. And that's really our whole goal when we're taking care of our older adult patients. And so frailty, we sometimes see this and we hear this and think of it as being synonymous with aging and disability, multimorbidity, but it's really not. There are a lot of components that are related, that happen normally with aging, that increase the risk of developing frailty. But again, it's not a one-way street. And certainly there are folks of similar chronologic age whose body systems maybe are similarly still functioning or have experienced a functional decline, that are frail, and many that are not. So it's not synonymous with aging or normal aging. It's also not the same as disability. There are folks who are disabled for a variety of reasons and have the coping strategies and ability to continue to, again, function independently and to respond in the face of stressors. While we know that multiple comorbidities increase the risk of frailty, and frailty increases the risk of not doing so well with those multiple comorbidities. Again, they're not the same. It's not uncommon, especially in what I do, homebound frail older adults, that there's not a lot of chronic medical conditions in some of our, particularly, very, very old folks, but even at that, and they just don't still have that physiologic reserve to recover. And while normal aging, okay, and then while, we often see this, particularly when people are in the end stages of their frailty course as, irreversible. We're not going to be able to get that person back to, that level of independence, that they've had in the past. When we identify those at risk of frailty or those with early pre-frail or early frailty syndrome, there are things that we can do to slow down and or reverse the process. This graph, again, this graph is showing kind of the normal trajectory of physiologic changes that occur throughout the body as you get older. And there's not, specific cutoffs here, or that midline is not necessarily 50, but you can see that the different body systems have different rates of decline normally with age. So things like our reproductive systems, that declines a lot faster. And so maybe that middle line is about 50, because that's kind of about the time when it becomes more challenging to reproduce. Whereas our GI system really doesn't experience a lot of change throughout the whole lifespan. And then other things, your neurologic, pulmonary, cardiovascular, that decline is pretty consistent throughout, even early mid-life kind of time frame where those declines start happening. So it isn't just, old age, it's just the progression of things along the way. And important, again, because those things happen, and frailty, like most geriatric syndromes, is a combination of normal aging, illness, psychological and psychosocial or social determinants of health, and how all of those pieces come together. So how common is this? One of the big challenges is that throughout the literature, there's been all kinds of different definitions used to describe frailty, but suggesting that there's probably over the age of 65, about 25% of older adults meet measures of frailty, and then that getting upwards of 45 to 50% by the time that folks are in their mid 80s. And where we show that increased risk, certainly, again, those aging changes are part of it. So we do see higher risks as the age increases. Women, Hispanic and African Americans have higher rates of frailty, other migrant groups. And then when you look at lower education, lower socioeconomic status, those with social isolation, all of those groups are more likely to experience frailty. So there are kind of two-ish main assessment tools that are described in the literature. One is the Fried frailty phenotype, and the other one is a frailty index. Now, I'd suggest that frailty index is definitely much more of a research tool or a case finding tool if you're searching through the EMR, and I'll explain a little bit more, whereas the frailty phenotype really gives us kind of those components to look at to identify people who are maybe at higher risk. So do they have low appetite, or have they experienced weight loss? It's a pretty easy kind of yes, no question. Are they experiencing exhaustion? So that early fatigue with activity, or just not having the energy to do activity. Are they slow? So slow walking speed, right? Are folks get up from a chair and you're kind of taking your time walking along with them? Have they had muscle weakness or muscle loss? Grip strength is one of the things that we can use to measure this, or particularly extension, right? So one of our exam, right, is squeeze my hand, push me away, pull me towards you. That pull, particularly we can see being very weak. And then the low energy expenditure, which goes kind of along with the exhaustion piece as well. And so those are things that we can observe, clinically in our patients and our clients pretty readily. And as those characteristics add up and that score gets higher, that's where one or two, we're thinking maybe pre-frail. When we get to 3 of those things, we are meeting those frailty characteristics. And then the frailty index itself is an accumulation of deficits. When they've looked at in the literature, it's anywhere from actually 40 to 50 different categories. And it's a kind of a percentage. And one of the unique things about this is it can be applied in different clinical settings with different potential markers of frailty. So you might have, I'm just going to name off 5, weight loss and slow walking speed and hand grip strength. And do they have heart failure and do they have COPD? Amongst a whole list of other things. And in another kind of protocol for it, maybe they're digging much more into, instead of heart disease, maybe they're looking at peripheral vascular disease or some other components. Again, with 40 or 50 of these, there's a lot of options, but it can be kind of tailored, which also means it can be tailored to like your EMR if you are doing some case finding types of things, for how your EMR would be documenting these deficits. And then it's kind of that percentage. So it's the total number of deficits versus those things considered. Looking at, again, the frailty index in general, there are specific cutoffs along the way. So weight loss, have they lost 10 pounds? Do they feel like everything they do is an effort? What is the walking speed for that 15 feet, and sex and height become are variable. So the cutoff on that specifically is variable. How much energy are they actually expending? And then weakness based on a hand dynamometer. And again, that cutoff based on sex and BMI are part of that. So you can use these specifically and specifically measure them. At the same time, you can also kind of use yes, no types of questions. Do they seem unusually slow? Is their hand grip seem unusually weak? Have they lost weight? But there are lots of other options for Frail Scale, some much more clinically based. Again, the Frail Scale that's down there on the bottom is really looking at yes, no to the frailty index. We can look at gait speed alone. Edmonton Frail Scale, right? So there are options. So, and again, kind of thinking about EMRs and different documentation systems may use different scales, slightly different cutoffs. So just being aware of those. And again, while frailty is its own unique geriatric syndrome, you can start this cycle of individuals where maybe the person does have some chronic illnesses with heart failure, COPD. And so because of the burden of that illness and those normal aging changes, they develop frailty. And so now they're frail, they're exhausted, they're weak, they're losing weight, and now they don't really have the energy or ability to continue to do their ADLs or their IADLs like they did in the past. So they develop that disability, they restrict their activity and engagement in the outer world more, become more socially isolated, so they become more frail, and rightly, you can see how the cycle kind of starts. And we know that frailty, even when they adjust for all of those other things, the level of disability, the chronic illnesses, age, is associated with all kinds of less than ideal health outcomes. So people don't recover from surgery as well, both urgent as well as routine or elective surgeries. They don't manage with their chronic illnesses as well. So particularly folks with heart failure, peripheral vascular disease, COPD, their outcomes are worse. Because they're not out and about, social isolation becomes much more of an issue. Which can coincide or be comorbid with depression and anxiety. That lack of social engagement, we also know, increases the likelihood of people's dementia getting worse. again, kind of feeding into this whole cycle. And folks who are frail are higher risk of being hospitalized, higher risk of winding up in nursing homes, and higher risk of dying, again, even when we control for all of those other factors. And so what can we do, right? So if we identify these folks early, or identify those who seem to be at higher risk of developing frailty, honestly, it's all of those good lifestyle things that really can impact a difference. So helping to create with them a plan to live a healthier lifestyle, providing some nutritional support, whether that's supplements, whether that's thinking about how to use whole foods in order to support nutrition better. Engaging in particularly resistance training has been shown to be effective, but also endurance training. Looking for your vitamin deficiency. Vitamin D has been associated with frailty. Thinking about those behavioral health supports, particularly when people with depression, anxiety, those that are socially isolated, those with cognitive impairment. How do we best support them through that? And really, that's to prevent other negative outcomes that speed that frailty process along. And how do we develop a chronic illness management plan with them that optimizes their function and their disease control, because doing all of those things really can, and there are studies that show, particularly in that pre-frail and early frailty, people do transition back into that robust or that non-frail situation, and upwards of potentially 20 to 30% of people in that really early stage can recover. So we can really change that course and that trajectory for these individuals if we identify it early and put together good plans to intervene. That being said, there are folks who, for a variety of reasons, we meet for the first time or meet along the way that their frailty continues. And it can also become really that terminal course, or people can be terminally frail, in which case then we have to rely on some additional colleagues to help support individuals. And that's why I really like this graphic, just about how, you can see how it's not just the medical, it's the social determinants of health, it's family, it's the pharmacy, it's all of these pieces that we still have to pull together in order to best treat frailty, as well as any of the rest of our geriatric syndromes. I will stop sharing for a moment and open up for any questions. All right. So next time I'm going biochemical then, that way there has to be questions. All right.
All right. Thank you.